Welcome back to the Transform Your Mind to Transform Your Life radio, podcast, and television show. I'm your host, Life Coach Renee Young, and sitting in the guest chair today is Dr. Brandon Ramakko. He is the author of Pain is Not a Life Sentence. And Dr. Ramakko and I are going to be talking today on the very important topic of how to eliminate chronic pain. Welcome, Brandon.
Thank you. Welcome.
Okay, all right. Excellent. All right. So listen, so like I mentioned, Brandon, Dr. Ramakko and I are going to be talking about chronic pain and nerve pain. So let me first of all ask you, Brandon, to share your backstory with our audience. Like, why did you become a doctor? Why did you focus on pain? I know from your reading the summary of your book that you went through chronic pain and nerve pain. And that's basically why that is basically what your work is all about. So can you share your journey with us, please?
So I was a college physics teacher in Montreal for many years. So a full-time teacher, had a good job, 4 months of vacation, pretty happy with my life with that part, and didn't have anything to do with healthcare, nothing to do with biology. In fact, I remember in grade 10 science, there was a module on biology, and I was like, I don't want anything to do with this ever again. I can't memorize anything. This is not for me. But life throws you curveballs. I had numerous problems. My family members and friends had numerous problems. And just a lot of people weren't getting solutions. And for myself, I had chronic neck pain. My neck would lock up and spasm. And I just thought, well, once a month, I won't be able to move my neck for a week. And I guess that's just the way it is for the rest of my life. What really struck me, though, was after being hit by a car. And afterwards, I couldn't use my knee anymore. My knee would lock up. And at the time, I was cycling to work just for commuting 30 kilometers a day, every day. I was doing 15 hours of gymnastics training every week. I was a very athletic person. And all of a sudden, I couldn't do anything. I couldn't do stairs. I couldn't cycle at all. My knee just wouldn't work. And, waiting 8 months for a doctor's appointment in the Canadian system, they said, okay, I see you can't do stairs. Well, is there an elevator at work? Yeah. Then you're fine. There's nothing wrong with you. You have an elevator. Now I got really depressed after that. I did go see other doctors and I got similar answers. I saw physiotherapists and I just wasn't getting anywhere with my neck problems, with my knee problems. I had joint pain in my hands and feet as well. There's just no answers. And I was a physicist. I knew physics and math, but if I tried to read research papers in healthcare, I didn't know where to start. I just didn't have the background. So out of frustration, I was like, okay, you know what? I'm going to have to do this myself. And so I did. And obviously I wasn't content with just knowing enough. I needed to know as much as possible, in particular with a focus on chronic pain, the pain that isn't solved any other way.
All right. So you went to medical school and focused on that, and that was your thesis. I'm just filling in. So that's what you did?
Well, so this was sort of like a split-second decision, out of frustration. I'm going to do it. Medical school is quite the lead up to get into medical school. Now, what I didn't know until maybe just before I made my decision was the Doctor of Chiropractic programs are actually quite robust. And actually, their board exams is a very robust board exam. And the courses are at the same level as the medical doctor program. Now, sadly, a lot of chiropractors, they throw out that information as soon as they graduate and they focus on the traditional techniques and traditional teachings of the first chiropractor. My goodness, they worship that guy. But the programs themselves are quite robust. So I did a Doctor of Chiropractic program but I did it in a state where chiropractors are primary care physicians. So I
Okay.
learned minor surgery, I learned obstetrics, I learned basically everything except more of a focus on rehabilitation and sort of physical therapy over drugs, which is actually good because my problems are musculoskeletal. So
Mhm.
having that focus was better. And I like the school that I picked because it was evidence-based. So the solution to everything wasn't crack the neck, crack the back. The solution was, oh, what does the research say? The research says, okay, this exercise. The research says, this treatment with this machine, or sometimes research says surgery. So
Mhm.
I picked a good school and a good place to do that in. So yeah, it's a doctor of chiropractic instead of a doctor of medicine.
Okay. All right. That works. That works. As you were talking about the problem with your knee, I am one of my last interviews was a doctor that he was doing regenerative gene therapy. And I
Yeah.
was scrolling Instagram this morning, and he had a video on there with an elderly woman in her 70s, and her knees didn't work. So he's doing injections or something. I wasn't quite sure what he was, some kind of therapy, but injection wise. But basically what he and she was saying, that if your knees don't work and if you can't move, then you start to lose muscle, you start to decline. So when they're telling you to use an elevator and you're pretty young,
Yeah.
when did you get hit by the car? What age were you?
So I think I was 27, 28.
Oh, wow. Wow. Yeah, that is too early to sit in a chair. So
Yeah.
I'm glad that, yeah, but you're very right. We're going to get into all this, in this episode. But what you're saying is the doctors are just saying that chronic pain, deal with it. So, okay. All right. So that was a great backstory. So now you there's several letters behind your name. So did you have some different skill sets in the chiropractic industry? So tell us what all the things that you're qualified for, you got certificates for, that you get all these names. I see a DC, I see an MS, I see a DIANM, I see an RMSK, I see a DIPIBLM. So what are all those things?
So I found my education, although good, it wasn't perfect. And I wanted to actually, this was inspired by starting to work with patients. Like I wasn't good enough. I wasn't where I needed to be, basically, to help these people. I
Mhm.
needed more. And so I did more. That MS is just a master's of science that's related to my physics. I was doing a PhD, but ended up quitting. But so that's related to physics. The DIANM is a diplomat status with the International Academy of Neuromusculoskeletal Medicine. That is an interdisciplinary specialty, requires a few hundred hours of study plus a few board exams. So that's open to medical doctors, chiropractic doctors, and physiotherapists, and osteopathic doctors as well. And that specialty is, I picked that one because that is a specialty for diagnosis and management of musculoskeletal conditions or neuromusculoskeletal conditions.
Mhm.
So my title, or what they trademarked, is a certified neuromusculoskeletal medicine specialist.
Okay.
So
Sounds
I
good to
imagine
me.
myself, it's sort of like a house. If someone can't diagnose someone, they come to a specialist
Okay.
who is
Right.
specialized in diagnosing and managing.
Mhm.
So that was really eye-opening, and it was just really, really good. And the medical doctors taking it as well are like, wow, this is really good. Everyone should really have to go through these programs.
Right.
So that's that program, very, very useful. The next one, RMSK, that is actually also typically a medical specialty.
Mhm.
It's registered in musculoskeletal ultrasound or sonography.
Okay.
So I am basically, that's a radiologist certification to use ultrasound imaging
Mhm.
on muscles, tendons, joints, nerves. I didn't know this at the time, but sonographers, when they go through school, they don't learn how to scan muscles and joints and nerves. It's not part of the standard curriculum. It's additional training.
Wow.
And the technology, I guess people have only been doing it maybe the past 10, 15 years. The certification has only been around, I think, 11 years. And I wanted to do it, in particular because the technology is getting so great. I was able to purchase one for $5,000.
Mm,
And I'm able to get images that I normally would have to send someone to an MRI for.
mm,
So send
nice.
someone to the hospital, they get billed $1,000, an MRI machine, $1 million, multi-million dollar machine. I can take images in the office, 5 minutes, I get the same answer. And
Wow.
not only, like, I think it's going to be the stethoscope of the future. I think
Mm,
more and more doctors are going to be using it. I honestly wouldn't see a doctor for musculoskeletal problems who didn't use ultrasound. Now, they don't necessarily need to have the certification. They can have a buddy show them how to use the ultrasound.
mm.
But doctors that use it for injections, for example, can put the injection exactly where it needs to go. There's still a lot of old school doctors. Yeah, I sort of know where I'm going. It'll be
Right.
fine. But yeah, we have the technology. The technology's gone cheap. It's gone small. It's the size of a cell phone. Um,
Mm,
so I got that. And now I'm able to not just send someone for an image once, I can image them every single visit and make sure that's progressing.
right. That's pretty
So
good.
yeah,
I'll
so
tell you
look
my
for
story when you're
doctors with
done,
that.
because I actually have a story like this. I didn't even remember it until we started talking. Anyway, go ahead. Let's talk about the last one.
So that one, DIP IBLM, diplomat status with the International Board of Lifestyle Medicine. They're similar boards. They're all part of the sort of the same collection. The American College of Lifestyle Medicine, the American Board of Lifestyle Medicine, they're all part of the same group. Medical doctors don't receive a lot of training in things that don't require surgery and drugs.
Mm,
They don't receive any training on how to coach patients, how to develop an action plan, cognitive behavioral therapy, motivational interviewing. They don't cover any of this stuff. They also don't cover the evidence for preventing disease or
mm,
reversing disease.
mm.
They cover the progression of how to add more drugs as someone's getting worse, but they often don't cover, okay, how do we take people off the drugs if they get better?
Is this in Canada or the United States?
This so
Everywhere?
international is for international. This movement in medicine started in the States with the
Yeah.
American College of Lifestyle Medicine. And
Yes.
I just love this movement that, okay, let's not focus on the drugs unless we have to.
Right.
But if there's an effective something effective that we can do that doesn't involve drugs, or in addition to drugs, let's do that.
Right.
It's not as profitable because they have to sit down with the patient and talk to them. But there are doctors out there who want to do a better job and who are
Yes.
getting these diplomas. So if you want to talk to a doctor who is probably going to talk to you, coach you instead of just throwing drugs at you, then look for DIP IBLM or DIP ACLM, American College of Lifestyle Medicine, or American Board of Lifestyle Medicine. I'll give a quick example and then I'll get to your story. Let's talk about type 2 diabetes. Early type 2 diabetes is 100% reversible. Not, oh, it depends on your genetics. No, I don't care if your whole family has type 2 diabetes. If you catch it early with lifestyle modifications, it's 100% reversible in the early stages, lifestyle modifications. Most doctors don't know that. And if they do, they're not convinced they can coach the patient to actually do the lifestyle changes. They just give up, give them metformin,
Right.
wait a while, start giving them insulin, because you have to
Yes.
coach through this. It's hard
Yes.
to make lifestyle changes, but it's reversible. And a lot of people don't know that.
Yes. Yes. Well, you're very correct. I've heard this several different times where they don't teach you anything. They don't teach the doctors anything about nutrition. You're probably right, but they're not teaching them anything about coaching. They're teaching them, hey, if this presents itself, this is the drugs. Which is why I asked you, this is America, because I know America is very capitalist, and you know, the drug people are spending billions to get these
Mm-hmm.
drugs on board, and then they spend, you know, years trying to get the doctors to feed it to the patients. So you're right. It's no preventative care. It's just, and even the insurance companies. You know, what I do here is educate people, and I'm educating myself as well. You know, I had a doctor that has one of the top books come on here and talk about medicine 2.0 and medicine 3.0, where medicine 2.0 is, you know, just treating the problem. Medicine 3.0 is preventative. But nobody's going to medicine 3.0 because they're just, so I understand exactly what you're saying. So I'm glad that you decided that you wanted to, you know, you got your doctorate, but you wanted more experience, or more training, I should say, in order to really actively help your patients. Now, the story that I have, and I didn't even remember it, but I had pain in my knee. So I think they said it was arthritis pain, or the fact that, you know, the ligaments in your knee is it's not bone and bone yet, but it's getting there. So I was listening to my pastor preach one Sunday, and he was saying that a certain amount of most of the elderly are going to get knee replacements. And then I heard Oprah talking about knee replacement, and everybody's talking about their knee replacement. I said, you know what? I'm going to go to the doctor because I don't want to wait until I need a knee replacement. So I went in and he did the scan, just like you're talking about, in the office. And then he gave me one of those injections. And it has actually worked. It's been over 6 months and I haven't had any pain. But what he told me is that the scan shows them exactly where to put the needle. So that's it's probably the same kind of machine that you have,
Yeah,
right?
yeah.
Yeah. So I didn't even remember my story, but yeah, but I walked with my pain. I mean, I didn't baby it. It was paining, and I walk a 5K every day because I know that it was important. I also got heel spur pain, and I walked through it anyway. But the knee replacement thing scared me. All right, so that's a good introduction to what we're going to talk about today. So, why is chronic pain such a problem with the, you know, the knee replacements and the what's going on?
So you touched on it when you're talking about the regenerative medicine. You know, once you stop using it, you end up with muscle problems. So people's chronic problems, they can evolve. It can start as an injury, and they still assume it's that original injury, just perpetuating. But it can develop into multiple issues that are overlapping. And everyone sees the problem through the lens of their specialty, so they don't see the whole picture. So they treat whatever their specialty is, and then you feel a little bit better for a while, and then it comes back. Or you only feel a little bit better and you don't get rid of it entirely. So that's one issue, is that's often overlapping problems that have changed from the original problem. The other issue is that chronic pain has a mental component to it, or it can have a mental component to it. A central nervous system component to it involves the nerve cells basically in the spinal cord as well. And that needs to be addressed as well for some. So they sometimes need the help of a counselor. There is one study, now it was a small study. I doubt every study would show such amazing results. But in this study, they isolated people with very, very chronic pain. And the type of chronic pain that they called central sensitization. And they could tell they had this because the amount of pain that they would experience didn't reflect reality. Like they just touched the skin, ouch. Well, we know we're not causing damage when we touch the skin. So these people had real chronic pain, really real sensitivity to pain. And they took time. They took time to explain how pain works, how it works in the brain, how it works with the sensors. And just taking the time to explain pain decreased pain by an average of 30%. Just taking the time to explain. But it's not profitable to do so. And it's a for-profit system.
Yes.
So for profit, we need to do a real thorough investigation. We need to constantly reevaluate patients. That's another thing, reevaluation. How many physical therapists be like, okay, this is your diagnosis. Okay, we're going to do these exercises, the same exercises week after week after week. Where if you're plateauing, if you don't improve 2 visits in a row, you got to change things up, reevaluate it. The pain might be coming from somewhere else, get more imaging, do different exercises. So you need reevaluations, you need to check for multiple overlapping problems, you have to work with the psychology, you need to explain to the patient, you need to take your time. It's a lot, and it's not profitable to do a good job. So chronic pain perpetuates. Oh, one other thing is poor education in the medical community, I'll include the chiropractic community as well.
Right.
And I'll give you an example of hip pain. There's a lot of people out there diagnosed with trochanteric bursitis. And it turns out, now I also learned trochanteric bursitis when I was going through school, and medical doctors, they learn trochanteric bursitis. And then I did my specialties, both the imaging specialty and the neuromusculoskeletal medicine specialty, and they both covered, that's not a thing. They can do surgery. They can take out the bursa. Bursitis means inflammation of the bursa. They can take the bursa, throw it out. The person's pain doesn't go away. So it's not the bursa. The bursa, if there's fluid in the bursa, because they would see fluid in the bursa and say, oh, it must be a bursitis, it must be inflamed. But it turns out you get fluid in the bursa if the muscles aren't sharing the workload properly. If there's a muscular discoordination, it irritates the tendon, and that tendon moving in an irritating fashion causes extra fluid to build up in the bursa to add more cushion to it. But the bursa itself isn't painful. It's actually the tendon that is painful and the muscles that are painful. So you don't, well, actually, this is one case where if they do find a tear in that tendon, surgery is amazing. Even if the tear happened a long time ago, even a full rupture, they can do surgery if it's the right diagnosis. I'm not just a conservative care. If surgery is the right thing, get the surgery. But a lot of these people, they just need to recondition the tendon, strengthen the tendon, and get those muscles working properly, get rid of the muscle pains, which maybe we'll talk about later a bit. And maybe if they have scar tissue, basically get rid of other sources of pain, and they can often eliminate their chronic trochanteric bursitis hip pain. Arthritis too.
Right.
Arthritis. A lot of people have arthritis or disc herniations, for example, on imaging. Doesn't correlate very well with pain. They took
I'm supposed to have arthritis in my knees and in my back, so which is a good, so one of the questions I have here is, what are the common causes of chronic pain, and are these causes treatable? So is movement good or movement bad? Because
movement in general,
I've heard that motion is lotion. Someone has said that motion is lotion. But let's say that I have a knee pain or I have a hip pain. When I walk, I think it gets better, or it doesn't hurt when you're walking. But people might think that walking or something is going to aggravate it. So what is the right way to handle that?
Yes to both. Yes, motion can be aggravating, and motion can be the solution. I'll use the knee as an example. So the knee, one of the main set of muscles in the knee is the quads for 4. Typically in people who get arthritis of the knee, which by itself typically isn't painful. It can be painful, but most arthritis is not painful. But if the quad muscles, if the vastus lateralis, if the outside muscles of the knee, of the quads, have taken over, and basically you're only using half of your quad muscles. So the quad muscles, they're supposed to be balanced. Some are on the inside, some are on the outside. So they pull the knee evenly. If it's being pulled unevenly, then it's pulling your knee sort of crooked. So a lot of people get arthritis more on the inside of the knee than the outside of the knee, and it comes from this muscle imbalance. And so if you have this muscle imbalance, it's more likely your knee is going to be irritated. So if you rebalance the knee, get the muscles inside, outside, working it correctly, your knee will be less prone to irritation.
And do you have to like go to the gym and get that, do some exercises at the gym or at home, or how do you get them balanced?
This is another frustration of mine because a lot of people go to a personal trainer or they go to, maybe they go to a physical therapist, but the physical therapist is busy, maybe just sends you to their assistant to do the exercises, and they think of things in just one way. Okay, the protocol is to do squats, so they just do one squat. They don't necessarily tailor the squat. Okay, this person has atrophy of this one muscle. We need to do a special squat just for this one muscle. And personal trainers don't learn how to target just one of the quad muscles. It's just how to target the quads. So that is a frustration.
Okay.
And I don't have an easy answer for you. I am making sets of videos online, which are going out for about one will go out every 2 days from now on.
Okay.
And I do describe some of these exercises in the book, although I didn't want to be an exercise book.
Okay.
That will be book number 3. It's a trilogy coming to answer all these questions.
Okay.
But
Well, I just wanted to answer whether it's you said that the pain was because of an imbalance, and I want to make sure that the imbalance could be corrected by exercise. I mean, I know
it can
we're
be.
in a podcast, so we can't really show the exercises, but I just basically want to know. So what you're saying is then that in the answer to that question is that chronic pain is treatable by learning the cause of it and working around it by exercise. Would that be the answer?
By specific exercises.
Okay.
Ultimately.
Okay. All right.
For every problem, it might be a different exercise.
Yes, of course, right. So,
yeah.
Chronic pain are usually in the joints, whether it's the shoulder, the knee, the hip. You talked about bursitis. Those are where, right. So yes, exercise. That's very important. And you can go to the gym and just mess around and you not know what you're doing, or you can go to a physical therapist and know what they're doing and work the specific muscle. So that's pretty good. So what happens if you have this chronic pain and you go to a physical therapist and you're pain free and then it comes back? How does that work? Why does it come back?
So typically that comes back because it's the body hasn't been trained enough.
Okay.
And sometimes it's a lack of variety, or it's a lack of the physiotherapist really fine-tuning the exercises, modifying them after you've done them for a bit, modifying them to completely get rid of your problem. Just to give you an example, I'll use the neck. The neck is prone to something called functional instability. Someone hurts their neck, let's say a car accident, the large muscles of the neck spasm on to protect the neck, basically to splint it. And you can't really move your neck for a couple weeks. Then afterwards, your brain has forgotten how to use the tiny muscles of the neck. It hasn't used them for 2 weeks. And there's actually close to 100 tiny muscles in the neck there, segment to segment. And that's really complicated. It's much easier for the brain to just use the big muscles. So it starts to default to these big muscles. So these people complain that the large muscles of their neck are always tight. They have a very stiff neck. And so if they go to a massage therapist or maybe their physiotherapist works out the tightness in their muscles, they'll be like, okay, yeah, it feels loose. And then 20 minutes later, 30 minutes later, the neck will be tight again. Well, of course it's tight. The brain was like, why are you relaxing those muscles? I'm using them. Right? So ultimately, you have to teach the brain how to use those muscles that forgot about. And then you also need the treatment. Then you relax the muscles and then they stay relaxed. And then the treatment sticks. So it's a combination of getting rid of muscle pain, scar tissue, tendinosis, like getting rid of pains, but then also having the training, again, balancing the muscles, making sure the muscles are working correctly, making sure your brain knows how to use the muscles and is using them correctly. It's really the whole picture. And again, also the mental stuff. You might need to see a mental health counselor or at least a doctor who is going to coach you on the central sensitization. There's a lot of layers.
Yeah, because you're right. A lot of people you mentioned earlier that they're thinking that they have pain or they're reacting to a touch and it's just all in their head. And people go to the doctor saying, you know, they have pain all the time and it's all in their head. That's very true. All right. So your book talks about nerve pain. And my husband actually had nerve pain. He had to have back surgery because, you know, one of his discs was pressing on his nerves. And, you know, right now he's going through the nerves regenerating. So
Mhm.
tell our listening audience, how do you get nerve pain? And is there a way to eliminate nerve pain or regenerate the nerves?
So yes, maybe. Nerves can be damaged for a lot of different reasons. If it's chemotherapy, well, you have bigger fish to fry if you're on chemotherapy. Um, of course, chemotherapy, you're trying to kill the cancer, but as the drugs are killing the cancer, it's damaging your nerves. And so that, whether that recovers or not, that is beyond the scope of my book. I don't delve into chemotherapy. I don't delve into diabetes. You know, if you're far along with a uncontrolled type 2 diabetes or type 1, it starts to affect the nerves. I don't delve into sort of chemically induced nerve damage in the book.
Mm.
I have good news about mechanical nerve pain, or mechanical caused nerve pain, such as compression by a disc in the spine, is
Mm.
that often those are treatable, and if they're treatable quickly, it's completely reversible. It often heals very well, and the nerve does come back. Sometimes it takes as long as a year, but it very often does come back. But let me get into two common examples. I'll talk about back and sciatica. I'll use air quotes here that you can't see,
Yeah.
necessarily see if you're
Well, that's
listening.
what my husband has. So I'll get your book for him. Go ahead.
Okay, so I'll start with the quote unquote sciatica, because I would say maybe 10% of people with chronic sciatica actually had nerve issue pain. I was able to 100% eliminate their pain without doing anything involving nerves. Now, that was my population. In another population, maybe it's 30% that it's not actually the nerves. But it's used incorrectly so often that if you look up the medical definition of sciatica, it means, medical definition, pain by the sciatic nerve or any pain down the back of the leg, because it's diagnosed wrong so often that any pain down the back leg is called sciatica. Most of the time, it has been myofascial trigger points. So myofascial trigger points cause, these are nasty muscles. These aren't just a tender spot. These nasty nodules are created when a muscle has been asked to stay on much longer than normal, such as spasming to protect during an injury. So people have an injury, the injury heals, and the myofascial trigger points still linger. They're still there. And what the confusing thing about them is they can cause spreading pain, and pain outside the location of the muscle knot. And these myofascial trigger points can last for years and years and years. And until they're treated, it can just persist. And every time the muscle is used, it triggers the pain. Every time the muscle is stretched, it causes the pain. Oh my God, so many people with hip pain, as soon as they lie on their side, it stretches the muscle, pulls on the muscle knot, they get their hip pain. So many people think they have arthritis hip pain and they have myofascial trigger point hip pain. But same thing with sciatica. It ends up being myofascial trigger points, typically in sort of the butt region. And the sciatic nerve comes out sort of lower butt, but I'll push in the upper butt region, and they'll say, "Oh, that's my pain. I feel that all the way down my leg." I'm like, "Okay, great. I have the treatment for that." Myofascial trigger points, there's an easy at-home treatment that you can do, or see a trained physiotherapist or chiropractor. You can eliminate myofascial trigger points, and as long as the muscles are sharing the work, the myofascial trigger points do not come back. If, of course, your muscles aren't sharing the work, then the muscles can still be spasming, they can still be overworked, and the muscle knots can come back. So most people's nerve pain isn't nerve pain for the leg. If there's weakness involved, particularly significant weakness, that's when I send someone for an MRI. That's when I send them for the surgery. The surgeons are so great at these discectomies. It tends to be a non-invasive surgery. They can open up the space for the nerve. I will say about disc herniations, if I take 100 people that have no back pain, 100 people, not even old people, people in their 30s and 40s, 30% of them, I think it's 30, 33, 34%, basically 1/3 of them will have disc herniations on MRI. Full-on disc herniations on MRI, but they have no pain. So that means that if you have pain and you go to a doctor and they take an MRI, 1/3 of the time they'll see a disc herniation. Aha, disc herniation, there's your pain. But is it? It could be. It could be. So MRIs are great for finding disc herniations. They're not 100% accurate at figuring out what the disc herniation is actually causing your pain.
Right.
In particular, because the disc herniation can persist on imaging basically the rest of your life, but might not create any more pain for you.
Right.
Do I have time to talk about one more nerve issue?
Yes, go ahead.
Carpal tunnel syndrome. Oh boy, carpal tunnel syndrome. The surgery, the carpal tunnel release, has a success rate around 30%. But they love to do the surgery because it's real easy, real quick. If your listeners see someone claiming, oh yeah, it has like a 98% success rate. Well, that's those studies that have those high success rates. Call the success if the pain goes from like a 9 to an 8.5. Ah, success.
Wow.
My
I would
version
think a
of
success is 0 pain, not 8.5. Wow.
Yes. So it only works 1/3 of the time. So because the nerve has a long path and the nerve can be pinched in multiple locations or in a different location, but that's the only location that they can easily do surgery in. So that's the location they always focus on. So of course, if you have numbness in your hand or pain in your hand, the nerve can be pinched, particularly if the pain starts to go into your forearm. Well, if the nerve was pinched at your wrist, the symptoms should only be past your wrist. So if you have symptoms, not just in the hand, but in the forearm, chances are the nerve is being pinched in the forearm instead.
Right.
And so you can treat the muscles of the forearm to give the nerve some more space in your forearm. You can treat the myofascial trigger points in the forearm. You can stretch the muscles that can be compressed in the nerve. And so I've had people basically get rid of their carpal tunnel by well, initially I got rid of the compression of the nerve, but with office work, I teach them how to stretch the muscle in their forearm, and they just stretch every day, and their carpal tunnel, quote unquote, carpal tunnel syndrome doesn't come back. But sometimes it's a combination of both. It can be compressed at the wrist, the forearm, sort of in the pec area, and in the neck. So there's a lot of places to check.
So that's a long nerve, huh? Okay.
Yeah.
Yeah, I had never had that one, so I have no rebuttal on that one. But I know people that are working on the computers all day long, they seem to get that. Yep. Right. All right. So let's talk about your book now. Your book is called Pain is Not a Life Sentence. I love it. A Guide to Understanding and Eliminating Chronic Muscle, Joint, and Nerve Pain. So why did you write it, and what do you want readers to walk away with after reading?
Okay, so I wrote it to try to encapsulate as much information as I could so other people wouldn't have to do what I did. They didn't have to quit their job to go back to school to learn how to take care of themselves. I mentioned my knee problems. My knee problems are gone. I mentioned my neck problems. My neck problems are gone. I don't want someone else to have to spend hundreds of thousands of dollars or over $100,000, years of their life just to understand what's going on. So I wanted to share as much, and this is book one of a planned trilogy, but this is, I think this is the most important one, and I just want to share it. Now, it doesn't necessarily have all the answers, but it has enough that you might even feel you know more than the medical doctors, at least in terms of your options. I mentioned the surgeon thinks you need surgery, but maybe the book will tell you, well, I could do surgery, but maybe I need to check these things out too. Or, oh, I know it's carpal tunnel syndrome. It's definitely the wrist. Well, is it the wrist? Maybe I should see a physiotherapist or chiropractor to have them check further up the arm, see if they can find other sources that could be contributing. And there's a lesson in the book: just never give up. Lots of doctors will be like, I guess that's as good as you're going to get. Lots of physiotherapists, well, I gave you the exercises. Those are the exercises. You just have to do those exercises more. If you're a doctor, if you plateau, don't give up. Get another practitioner. They might have given up on you. Don't give up on yourself.
Right. Yes. Yes. Yes.
So yeah, I want readers to walk away with just a greater understanding and just some hope that they can get down to the bottom of their problems.
Yes. Yes, very good. From our conversation, I know it'll be a great book, and it's an on-time book too, because a lot of people start getting chronic pain as they get older. I mean, it's almost like 100%. So you don't want to, like the lady that I was, that was talking on Instagram this morning. Yeah, I mean, you have to be able to move. And people, a lot of people either, go around, babying their pain. Oh, my knee hurts, so I can't walk. Oh, my shoulder hurts, so I can't lift anything. Oh, my this hurts, right? So you don't want to live with the pain. A lot of people saying, I'm never going to have surgery. So you're offering an option. You're offering an option of learning how to release this by either specific exercises, going to your chiropractor, physiotherapy, and just knowing that you can eliminate the chronic pain and feel better. And once you eliminate the pain, you can start moving, and that exponentially increases your lifespan and your longevity and your health span. So that's pretty good. Yes, this is an on-time book. And like I said, I deal with pain in my back, not as much anymore. And my knee pain went away. But my husband is still right now working with his nerve pain. And so I'll pick up a copy of your book and definitely read it for him, and I mean, have him read it and see what he can do because his problem started off as a disc problem that pinched the nerve. So you mentioned that your book discusses that, which is a skeletal muscular pain. So that's pretty good. So yes, so tell our listeners one, where they can pick up your book, two, how they can get in touch with you. You mentioned you have some videos and also your website.
So my book is available on Amazon. It's available in ebook, paperback, hardcover, and audiobook. And the audiobook should be available through iTunes and Audible as well.
Okay.
As for my website, it is www.drramakko.com, DRRAMAKKO.com. And I am posting videos there. Actually, all of my videos currently are there. They're being posted every couple days on YouTube. And I do have a Facebook page as well, but I would probably go to my website before my Facebook page, as everything is found on my website. They can even book sessions with me if they want to talk to me, if they want an educational session specific to their problem or specifically to answer their questions.
Okay. All right. So now that information is available on your website as well as linked to your YouTube channel, or do you want to tell me what's the name of your YouTube channel? Is it the same thing, Dr. Ramakko?
No, my YouTube channel is just Brandon Ramakko. I made it
Brandon?
a few
Okay,
years.
just your name? Okay.
Yeah, made it before I was a doctor.
Okay. All right. All right, guys. Well, listen, I'm sure that each and every one of you that are listening today have some form of skeletal muscular pain, because as soon as you get to your 30s or 40s, they start coming around. Right? Or even earlier, right? Or you can have an injury. We started off by saying a lot of these chronic pain starts with an injury. Yeah, my sister right now has been going to the chiropractor almost 10 years now, because she had an injury, a car accident that hurt her neck, and it's been going on forever, right?
Yeah.
Go ahead. You want to say something?
Yeah, don't let chiropractors say, "Oh yeah, it's cumulative. You need at least 12 sessions of cracking your neck to make it better." They're just, what happens is most people get better within 12 sessions on their own, and then the chiropractor just takes credit for it. Um,
Yeah. Well,
just
hers
getting
has
your
been
neck
more than 12
adjusted.
sessions. She goes to that chiropractor once or twice a month, and she's been going for years. Well, she goes for the chiropractor. She also gets a massage, but I think her neck problem is still there. So I
Yeah,
know that, everybody's, whether it starts from an injury or what my doctor says, use you use it or whatever. I think he says, right, wear and
bad
tear.
habits.
That's his words, right? Wear and tear. You're getting older, and that's basically what happened, wear and tear. So yes, Dr. Ramakko's book at least gives you knowledge, and I a big proponent of knowledge is power. So
Mm.
pick up a copy of his book, learn, because even if you're not there yet, you will get there. We're all going to have these aches and pains as we get older. So it's good to learn what to do and how to, have quality of life, because that's all very important. So yeah, thank you, Dr. Ramakko, for this very illuminating conversation. Like I said, I am personally involved with pain. My husband is, and my sister, my mom, everybody around me talks about pain. Both my husband and my mom, and I think even me sometimes have this sciatica pain. So yeah, your book is very good. From my conversation with you, and all the numbers behind your name or letters behind your name, I know that you did a really good job as far as what you've put into the book, because you're very knowledgeable. So thank you for
Thank you.
being on the show. Um, Thank you guys for tuning in to the Transform Your Mind to Transform Your Life radio, podcast, and television show. I bring you quality guests like Dr. Ramakko every week. If you're listening on YouTube, then I would love for you to press that subscribe button. If you're watching on iTunes, we'd love for you as well to rate, review, and subscribe so that the message reaches a wider audience. So as we wrap up, Dr. Ramakko, any last words?
No, you said everything I want to say very eloquently. Don't give up. There are solutions. Solutions often involve exercise, and I wish everyone luck in staying as mobile and happy and healthy as long as they live.
Yes, that's it. Mobile and healthy. Listen, I would hate not to be mobile. My life revolves around taking a walk every day. It is my pleasure point. So
Mhm.
yes, if you're listening to this and you can't move, then do something about it. Right. So, all right, guys. Thank you, Dr. Ramakko. Thank you guys for tuning in.
Thank you.
Until next time, namaste.